Good day and welcome to our tutorial session today on benign breast disease. This is a continuation of our series of lectures on breast diseases, and today we will begin with benign breast disease. This discussion is divided into two parts. So this is the first part of benign breast disease. We would have the second part of this lecture later on. So as a way of introduction, non-cancerous breast disease affects nearly every woman at some point in their lifetime. There are a variety of benign conditions of the breast, and some even mimic cancerous symptoms, but some are non-lethal. A thorough history and physical examination is important in making a diagnosis of most benign breast conditions because of the similarities that some of them may share. This could either be most benign breast diseases could either be in the form of epithelial origin or connective tissue origin, or even mixed, or could have a mixed component. So it's important we note that, and understanding the origin, whether epithelial or connective tissue, is important in understanding the various lesions of the breast. And I would indulge that you see my lecture on anatomy of the breast if you haven't. If you have, then you can continue seeing this video. Now, classification of benign breast conditions broadly is classified into benign breast neoplasms and non-neoplastic conditions of the breast. For the benign breast neoplasms, we have fibroadenoma, cystosarcoma phylloides, duct papilloma, and lipoma. Lipoma is, however, uncommon, so majorly would focus on fibroadenoma, cystosarcoma phylloides, and duct papilloma. And then for the non-neoplastic conditions, we have ANDI, which is aberrations of normal development and involution, and then inflammatory breast disease, mammary hypertrophy, breast abscess, Tietz syndrome, traumatic fat necrosis, and galactosile. These are non-neoplastic conditions of the breast. While for the neoplastic conditions that are benign, we have fibroadenoma, cystosarcoma phylloides, and then duct papilloma. So in this lecture, we'll focus on these benign breast neoplasms. So I hope you understand this classification. They are both benign conditions, but we have the neoplastic conditions that are benign in character, and then we have the non-neoplastic conditions. So this is a diagram showing the various parts of the breast and then the lesions showing where they arise from. Now, recall that the breast is made up of the glandular unit and then the stromal component. For the glandular unit, we have the acинus that makes up the lobules, that drains to the lobular ducts, that eventually drains into the lactiferous duct onto the nipple. And now this glandular component is lined by epithelial tissue, the columnar epithelium. Okay, that's for the glandular component. So there's an epithelial component in the glandular unit that lines the glandular unit, the glands of the breast. For the stromal component, we have the connective tissue. The connective tissue is colored gray here, or rather green here. And then for the fatty tissue, is colored yellow here. So various lesions arise from these components that I have just outlisted. That's the fatty tissue, the connective tissue, and then the glandular component. So from the lobules and the terminal ducts of the breast, that's the gland now of the breast, we have cysts. A breast cyst can arise from the glands of the breast. So a cyst is more like a fluid-filled sac that will be lined by epithelium, because we have an epithelial component here. So that's a cyst. A cyst can arise from the lobules or the acинus. And then we have sclerosing adenosis. Sclerosing adenosis just means abnormal proliferation of the glands of the breast. So when there's abnormal proliferation of the lobules or acinus of the breast, it gives rise to sclerosing adenosis. Then we have small duct papilloma. Remember, the duct has an epithelial lining too. So this epithelium can undergo abnormal proliferation, leading to a papilloma. So we have small duct papilloma. Then hyperplasia. Hyperplasia simply means proliferation of cells. So you could have hyperplasia of any components around here, any of the cells around here, either in the glands, either in the ducts, could have hyperplasia. Then for the large duct, we could have duct ectasia affecting the lactiferous duct here. Then we could have large duct papilloma. Remember that there's an epithelial line in here as well, so they could have papilloma of the large ducts. Now for the intralobular stroma. The intralobular stroma is that stroma just directly surrounding the lobules of the breast. Thus the name intralobular stroma. So it's majorly made up of the connective tissue, that's the fibrous tissue. So the lesions that can arise from that fibrous component now includes fibroadenoma and phylloides tumor. Fibroadenoma and phylloides tumor, they arise from the intralobular stroma of the breast that is majorly made up of fibrous connective tissue. That's this green component here. Now for the interlobular stroma, that is interlobule, from between this lobule now and this lobule, what is in between is majorly fat. So from this fatty component now, lesions that can arise include fat necrosis. So you could have traumatic fat necrosis affecting the fatty component, have lipoma, which is uncommon, fibromatosis, and then sarcoma affecting the fatty layer of the breast. So fibroadenoma is commonly referred to as breast mouse because it moves all around the breast. So on examination, you may find it in the upper outer quadrant, but before you know you find it in the lower outer quadrant. So it just moves around the breast. So it's called a breast mouse. But that's for the small lesions. That's for the small lesions. Now definition. A fibroadenoma is a benign tumor of the breast arising from the intralobular stroma. Remember that the intralobular stroma is that part of the stroma directly surrounding a glandular component and is majorly made up of fibrous connective tissue. I'm sure you remember that because we just talked about it. So the intralobular stroma. Now, fibroadenoma has a fibrous component, which we already know, and also has an epithelial component. Now the reason why it has an epithelial component is because remember that the intralobular stroma is directly surrounding the glands which have an epithelium. So if there's going to be an abnormal proliferation there would most likely be some epithelial contribution or component alongside the fibrous tissue that is majorly found in fibroadenoma. So a fibroadenoma will have a fibrous component and an epithelial component to it. Now for the etiopathogenesis, it's majorly an aberration of a developing terminal lobular unit. Remember that it's the terminal lobular unit that is directly enveloped by this intralobular stroma that has a fibrous component. So an aberration of a developing terminal lobular unit due to hormones. So we would see later on that fibroadenoma is commoner in the young age group between 20s and 30s. So that is the period whereby in the 20s the breast is still developing, or rather in adolescent period the breast is still developing as a result of hormones. So that development of the breast with hormonal involvement in that age group is what, when there's an aberration, that's what gives rise to a fibroadenoma. So types of fibroadenoma, we have the pericanalicular type, which is the commonest, and it consists more of fibrous tissue. And then we have the intracanalicular type, which consists more of glandular tissue. Okay, so we'll explain pericanalicular and intracanalicular in the next slide. So let's say this is a terminal lobule and its ducts. This is one terminal lobule and its ducts. Yeah, here this is one terminal lobule and its duct, and then this is another terminal lobule and its duct here, and then in between we have the fibrostroma. We have the fibrostroma surrounding the terminal lobule and its duct. So when the lesion surrounds is formed around this particular terminal lobule, so it's majorly formed by the stromal component surrounding the epithelium of this gland, is referred to as pericanalicular. So so when you see it under histology, you see an epithelium inside of it surrounded by stroma. I hope we understand. Remember that this part of this of the gland here has an epithelium lining it. So the fibroadenoma grows around it, pericanalicular around it, grows around it, and then it compresses on it most likely. So when you do a cut section, you see an epithelium inside, and then you see stroma surrounding it. So that is for the pericanalicular pattern. While for the intracanalicular pattern, it grows here in between this lobule and this lobule. So it grows majorly in the fibrostroma. So when you do a histology, the inside of it will be more of stroma, will be stroma, and then while the outside you will see the epithelium of the glands. So it grows and then compresses this epithelium, rather distorts this epithelium. So when you do a cut section on histology, you would see the inner part composed of stroma, fibrostroma, and then the outer part composed of epithelium. I hope we understand the difference. Anyway, it's just to help you understand the lesion as a whole. So the clinical features, it develops during the reproductive age group, 20s and 30s, and then the symptoms, usually painless, that patient will complain of a mobile breast mass that is firm and painless. It could grow big to become a giant fibroadenoma. So a giant fibroadenoma would not move around like a breast mass because it has become very, very giant. Now, treatment basically is excision biopsy. You just excise the lesion and the patient will be okay. So this is a diagram showing a giant fibroadenoma. So ordinarily, if you don't know the diagnosis that it's a giant fibroadenoma, on seeing this diagram, the first thing that will come to your mind would be a malignant breast lesion. Then maybe a cystosarcoma phyloides will come next, then before you start thinking of giant fibroadenoma. So cystosarcoma phyloides, it is an intralobular neoplasm of the breast. So just like fibroadenoma, it is also an intralobular neoplasm of the breast. So it's more like a rare variant of the intracanalicular fibroadenoma. Can we remember the intracanalicular fibroadenoma? Okay, it occurs between the two between two lobules. Okay, occurs in between two lobules, and then it grows so big to distort the epithelium of one lobule, of the lobules around it. So when you do a cross section, you see epithelial lining around the lesion, and then the center will be majorly stroma. Okay, so the pathology consists of cysts and a cellular stroma. So unlike fibroadenoma, it grows so rapidly to form cysts, and then the name phyloides actually means leaf-like. So it grows rapidly and forms leaf-like structures. So it extends into the glandular component, forming leaf-like structures, forming cysts, and then it has a very cellular stroma. So that's the characteristics of phyloides tumor. It's a rapidly growing tumor. It forms cysts, it forms leaf-like structures, and is highly cellular. There are pathologic types. We have the benign, which accounts for 60% of all cases. Then we have borderline, accounting for 15% of all cases. And then we have the malignant type, accounting for 25% of all cases. So this is a diagram showing a phylloides tumor. It is a rapidly growing tumor. So it even grows so rapidly to affect the skin, causes ischemia of the skin, and subsequently necrosis and ulceration of the skin. That's a phylloides tumor. So for the clinical features, the age, they can occur at any age, but most of them present in the sixth decade, which is 10 to 20 years later than the peak age for fibroadenomas. So most of them present later, at a late age. And then the symptoms is a rapidly growing breast mass, as I've earlier said, which may be painful. So it may start as a small lesion that rapidly grows. It may be painful, and then due to its rapid growth, the large mass may cause pressure necrosis on the skin and cause ulceration. So for the malignant variant, spread is usually hematogenous. Remember we said there are three variants: the benign, the borderline, and then the malignant. So for the malignant variant, spread is usually hematogenous, most usually to the lungs, and thus there are no axillary lymph node involvement. So there is no lymphatic spread in cystosarcoma phylloides. So excision biopsy is required in making a diagnosis. So when you excise the lesion, remove the lesion, you're able to make a definitive diagnosis of cystosarcoma phylloides. So duct papilloma is a small papillomatous tumor arising from the epithelium of the lactiferous duct near its termination at the nipple. So understanding the anatomy and histology of the breast would really help in understanding where these lesions arise from. So you don't have to cram the lesions. So just knowing where they arise from would just help you remember, oh, this lesion is from this lesion can occur. So it projects into the lumen of the duct and becomes dilated. It may become malignant if it has a fibromuscular core. Multiple papillomatosis is, however, pre-malignant and may become a duct carcinoma. Remember we said we have small ducts and large ducts. That's the lobular duct, we have the lactiferous duct. So from any portion of this duct, you could have papilloma arising. So the papilloma arises from the duct of the breast. And remember that these ducts are lined by epithelium. Now, it commonly affects women aged 35 years to 55 years. And then the symptom, recurrent bloody discharge from the nipple, is a major symptom of duct papilloma. And this symptom arises because you know that in duct papilloma, the epithelium of the duct is abnormally proliferated and there are blood vessels just beneath this epithelium. So there could be distortion of these blood vessels. The abnormal proliferation of the epithelium can even it can outgrow its blood supply and cause ischemia, and then there could be bleeding, there could be ulceration. So recurrent bloody discharge from the nipple is a major symptom in identifying duct papilloma. There are other things that can cause bloody discharge, but when you hear a woman complain of bloody discharge from the nipple and within this age group, you think of and then there is no palpable tumor, you think of a duct papilloma because there is usually no palpable tumor. So a galactography is done to outline the affected solitary duct. And then treatment involves identifying the affected lobe at surgery and excising it. So at surgery you identify the affected lobe and then you excise it. So in conclusion, we basically talked about three lesions: fibroadenoma, phylloides tumor, and duct papilloma. So if a young lady comes to you with a mobile mass that is painless, you suspect a fibroadenoma. If a much older lady comes to you with a large breast mass with skin ulceration with maybe no malignant symptoms, you suspect a phylloides tumor. And then if a lady comes with bloody nipple discharge with no palpable tumor, you suspect a duct papilloma. So I hope we were able to understand the different breast lesions we talked about and where they arise from using your knowledge of anatomy and histology of the breast. So references: Brown's Introduction to the Symptoms and Signs of Surgical Disease, and then Robbins' Basic Pathology. So thank you for watching, and I hope you learned from this video. So watch out for our next video on continuation on benign breast disease. Thank you.